Positive Life New South Wales. Positive Life is a peer-based organisation, so a non-government organisation, that represents people living with HIV. The main focus of our agency is to do peer support programs, which is around supporting people living with HIV to get into housing and employment, health education and social media campaigns, and then the final area is around treatments advice, policy advocacy and systemic advocacy to government. So providing advice or consumer representation into the New South Wales health policy agenda. So that's a little bit about who the agency is. I've been working as the CEO of Positive Life now for the last 3 years, and I've been employed in health services, drug and alcohol services mainly, and population health mainly, and also non-government organisations, so youth health, child protection services, family support services, and within the criminal justice system. So I've had a range of jobs within health services and community organisations since 1990, so I've been around for a while. Today's presentation, so it's great to be back and here talking about something that is very dear to my heart. Today's presentation is mainly going to be around policy and advocacy context for community dispensing of HIV medication. So what we did as people living with HIV and community representatives to get the community dispensing of HIV medicines into community pharmacy, the National Safety and Quality Standards, and how that informs our work as community representatives. Some surveying that we did of people living with HIV within New South Wales nationally and also in Victoria, and what that survey has taught us or told us, and how that informed the implementation of the policy announcement from the Commonwealth Government, and then some of the issues that are going on for people living with HIV and pharmacists as people are living with HIV are accessing their medicines within a local pharmacy or community pharmacy context. At any point throughout today's discussion, I would rather this be a discussion rather than me just standing up here talking at you or talking with you. So if there's any questions or points of clarification or thoughts that you have about the work, please feel free just to shout out so we can have the conversation as I'm going through the slides. So basically what had been going on for people living with HIV, our main way of, or our only way of getting our medication was, I'm HIV positive, I've been living with HIV since 2002, and I commenced medication straight away because I'm what's known as a rapid progressor. So my immune system, after the acute stage of the infection, didn't bounce back, and I continued to get sick. So I had to start drugs straight away. So luckily, HIV medications came into effect in 1996. So fortunately for me, I was able to go on the drugs pretty fast. Otherwise, that wouldn't have been a good thing for me whatsoever. The two main areas that was impacting on me as a result of the infection was neurocognitively. I was having problems with comprehension and memory as a result of the infection, and the other one was gastrointestinal. It was affecting my stomach in terms of my ability to digest food and also hold on to food. So food was passing through me quite fast. And so it was quite a scary time, but fortunately my doctor got me onto the drugs straight away. But the problem was, and has been for other people, is the only place that we could get our medications was from a hospital pharmacy, which was pretty inconvenient because typically they didn't do a lot of after-hours work. So there weren't very many after-hours clinics, and that would impact on people who were employed. So typically people would have to lie to their employer to be able to go and get their medications, and the frequency of getting our drugs, we would have to go sometimes once a month, once every 3 months, and typically we would have to take half a day or more off work to go and get our medicines. So we, as people living with HIV, have been advocating at a state and Commonwealth level, a national level, for over 10 years to try and get that changed and to allow us to get our medications from community pharmacy, local chemists. That announcement was made in 2014 by Minister Dutton. He was the Federal Health Minister at the time. And on the 1st of July 2015 was when we were able to start collecting our medicines from a local chemist. The strategy or the policy context within which that was actually located was both the national HIV strategy, which had a target of 90% of people living with HIV to be on antiretroviral therapies, and the New South Wales HIV strategy target, which is 95% of people. Our agency, as Positive Life New South Wales, has been advocating now the New South Wales government that we think that 100% of people at the point of diagnosis should be offered medication. We don't think that people having to wait 6 weeks to 6 months to start medicine is okay. We know from the point of infection, the time someone is infected with the virus, that it's doing damage to the immune system, that the secondary inflammation is quite difficult to manage, and if viral reservoirs are established within the central nervous system and the gastrointestinal tract, that typically, even though people achieve viral suppression, that there is still low-level viremia and virus progression, even though viral suppression is achieved. So from our perspective, we think people need to get onto the drugs sooner rather than later. If they choose not to take the drugs, then that's a personal choice, but we don't think that it's okay that people aren't offered their medications at that point of diagnosis, hence the 100% positive statement that our agency is now taking in relation to both the New South Wales and the federal health policy around this as an issue in terms of the dispensing and prescribing guidelines. So when I talk about the national safety and quality health standards, when I came into the job, our tagline as an agency is that we are the voice of all people living with HIV in New South Wales. Now, when I came into the agency, I said to everybody in the team and our board is 100% people living with HIV, so we're all HIV positive. So I said to the board, how can we demonstrate that? What evidence do we have to actually say that we are the voice of people living with HIV in New South Wales? So what we did, we set up a framework which is called our Consumer Consultation and Engagement Framework, and that then triggered a round of community surveys. So we're constantly surveying the community to actually find out what people living with HIV think about issues. So that actually then feeds into our policy and advocacy agenda and the way that we lobby government. So that we know that it's an informed position, not just from us as an agency, that it's also based on the thoughts and opinions of people living with HIV, both in metropolitan New South Wales and also rural regional New South Wales. So this is pretty much the intention of the National 2 Standard, which actually informs our consultation and engagement approach within the agency. Is that pretty straightforward? So we had the cost for employed, when we were doing the lobbying, we did make that distinction for people and for the government, because we were originally aiming for just those people who were unemployed, DSP dependent, that sort of stuff, or on have a healthcare card, you know. So when we were originally lobbying for that, we were aiming for that because we were really concerned about the health outcomes for those people. But that was a universal application of that decision by Minister Skinner. And the reason for that was because if we're aiming for targets around 95 to 100% of people living with HIV, there's only 28,000 people living with HIV in Australia and 10 to 12,000 in New South Wales. So if we're aiming for that many people to be on the HIV medicines, then we need to try and address all access barriers. So, and one of those access barriers, regardless of whether you're employed and earning $100,000 a year or not, one of those obstacles for people will always be payment. Any other questions? The health system at this point in time is around activity-based funding, and the issue is that the more people, the more occasions of service and dispensing items that people have within the hospital pharmacy, the more money the pharmacy gets. So I'm concerned, I haven't had that verified by anybody, but I am concerned in the back of my mind that this could also be a bit of a funding issue going on, where people are trying to hold on to patients as a way of keeping their numbers within their, so that they maintain their funding levels. But anyway, that's me being chatted. So that's some of the resources. This is where, so what we do is when we find out about pharmacists who are dispensing the drugs, this is a map so that people can just go on and they can try and find out if there's a pharmacist within their area who is already opting into a dispensing arrangement. So then they're not going to be like breaking new ground with this pharmacy, and they know that this person's already got some experience dealing with some of the drug interaction action issues, how to manage some of the side effects from the drugs, all that sort of stuff. So this map's there for people living with HIV to link in, and because this is an opt-in arrangement for pharmacists, then they can just send us their details and we just add this to the map so that more and more people can get their medications from the chemist. It's pretty good, it's user-friendly, we get really good feedback about this and it's being used quite with frequency by people, both service providers and also pharmacists. So the advice that we've been giving to people living with HIV, this is a bit of, since 2015, this is pretty much just some of the key messages within the communication strategy that we've been employing. And here are some of the issues moving forward that would be good for us to drill down into now. So basically we've got the largest population because New South Wales and Sydney was the gay mecca and the epidemic centre of the HIV epidemic or pandemic within Australia. We've got the vast majority of people with HIV in this state. So there's the stats around 40% of people living with HIV have limited income. So that's come back to the co-payment waiver issue. And the other issue that we've got problems with at the moment, we haven't been able, this is an intractable problem for us as the health system. So the problem is around around late presenters or advanced HIV disease. So in New South Wales, what that looks like is we're roughly still getting 50 people or more. So 10 to 14% of the notifications per year are still late presenters. So people diagnosed with advanced HIV disease. What that looks like is there's still, regardless of whether you go onto the medications and you become virally suppressed, people still have quite significant levels of impairment, in particular psychiatric and neurocognitive impairment as a result of the late presentation. So we haven't been able to break this. We've been able to reduce the numbers of acute presentations. We've been able to stabilise and reduce the number of presentations per year or notifications per year around HIV. So we are getting on top of it. We are starting to see a shift in the number of notifications occurring within particular populations. The problem is though we haven't been able to break the back around late presenters, which is heartbreaking at this point in time that we haven't been able to do anything about. So that's a bit of an issue. The other issue at this point in time, which is a big topic, is HIV and ageing with the population of people living with HIV getting older. There's been, if you track the notification data over the last 15 to 20 years, there's been a particular demographic of age group, and that age group is now in between the 45 to 50-year-old bracket. Back in the early days, that age group was typically between 32 to 38. So it's the same generation, are the ones that are responsible for most of the numbers. So this is the issue around multimorbidities. So these are, we did a survey, so New South Wales Health commissioned us to do another survey, and that was about people living with HIV access to mainstream and specialist healthcare within New South Wales and what the issues were going on. So we asked about notifications and diagnoses. So if you look, there's quite a significant number of people that have 2 or more diagnoses. So what that means in terms of the number of drugs, the number of health professionals we're having to see. We're going to see cancer specialists, we're having to see diabetes specialists, we're having to see our HIV specialists, we're having to see our GP. We see a lot of bloody doctors, you know, and that's not by choice. We don't want to do that, but we just have to try and maintain health outcomes and maintain our health to some degree or another. So drug interactions, managing some of the treatments that we're on. Like, there's going to be a lot of stuff coming up for you within the chemist around what this looks like for us. And this isn't going to get better. This is not going to get better. Back to the late presenters issue. Because we haven't been able to get on the numbers of late presenters, and because more of us are living longer with HIV, so we're an ageing demographic, these numbers are going to go up. So this isn't, we're not going to see a downward trend just yet. If anything, the number of diagnoses that we're going to be experiencing into the future is going to increase. Any questions? So here's a breakdown basically of where we're living in terms of our numbers as people living with HIV. So that's pretty straightforward. And this is the rural numbers. So the interesting thing we do as an agency, we do regional rural outreach. So we do about 4 to 6 visits per year, and we go around to different areas: Bega, Dubbo, Tamworth, Lismore, all that sort of stuff, Newcastle. And when we go around there, the number of people that we meet up with who think they're the only person, they've never spoken to another person living with HIV, it's really astounding. So if you look at these numbers of the number of people living in a particular area, and these people feel significantly isolated. They are extremely depressed or anxious. They don't want to disclose to anyone other than the doctor or their pharmacist that they're getting medications from. They don't tell anybody. They don't even tell their partner. It's very scary for them. So part of our role as an agency is to try and link them in with other people living with HIV in their community. Because just having a conversation with another person, there's something else, it shifts something in your head. So it makes a significant difference so they don't feel so alone. Because the more isolated and alone they feel, the more disconnected, the more they'll withdraw from life and the more disconnected they'll be from other people. And that's not good in terms of longer-term mental health outcomes. That'll compound issues. So for example, if somebody then deals with a cancer diagnosis and then their mother dies of cancer, or breast cancer, this is somebody that I've met recently in February this year, they're then coming to terms with accumulated grief. They've got an accumulated grief syndrome going on, and on top of that, nobody in their life knows that they're HIV positive. You know. So it's not a good scenario because they've got no one to talk to about what's going on for them, and it becomes increasingly problematic. So we're everywhere. We're not just gay people in gay Sydney. We're all over the place, and it's really sad how isolated and disconnected we are. So your job as pharmacists or interacting with us in a local chemist is going to be an important job. You know, you're going to make us feel more normal. You know, it's going to be an important thing. Well, it is an important thing. So some of the issues. Stigma and discrimination is a significant problem for us. How we've tried to deal with that up until now has been to try through a systemic advocacy arrangement, such as co-payment waiver or community dispensing of HIV medications, to try and normalise the infection as a chronic manageable condition, rather than it being a stigmatised condition. So that's how we've tried to deal with it up until now, but we're about to try and change that strategy. HIV disclosure is still the significant concern for people living with HIV, and they need to own that disclosure. People cannot take that disclosure away from them. I know of scenarios where a person has disclosed to their boss and then their boss has told all their workmates. You cannot do that. That is not okay. Still, nearly 55% of people living with HIV accessing their medication still express concerns about the chemist knowing their HIV status. But despite that, we're still hopeful that we'll get 65 to 70% of people living with HIV getting their medications from a community pharmacy. So that's about it for me. I've sort of quick through, there weren't many questions. So any questions at all from what I've just presented? All right, well thank you very much for your attention.